We can start the free paper session. The presentation duration of each paper is 5 minutes. And please stick to the time. Now I invite Dr. Anuradha to speak on our topic, blinded by aneurysm, sixth nerve palsy, and the silent role of sympathetic paralysis.
May I start, ma'am? Good morning, everyone. I'm Dr. Anuradha, and today I bring to you a case of unilateral sixth cranial nerve palsy, which was unique with respect to its associated features and how a careful clinical examination can help localize the lesion in such cases prior to confirmation by radiology. Abducens palsy is a common presentation in ophthalmology and mostly has microvascular etiology and is painless in nature. A painful palsy should always raise alarms to find out the cause of the same as promptly as possible. In the absence of immediate access to radiology, a careful clinical exam can lead to precise localization of the lesion. My patient was a 58-year-old lady, a known case of hypertension but non-compliant with medication. She presented in accident and emergency with acute onset headache and right ocular pain, along with giddiness and vomiting. There was no history of any other diagnosed systemic ailments of significant past and personal history. On general examination, the patient was tachycardic with blood pressure on the higher side. Central nervous system exam revealed a right-sided abducens palsy with no other focal neurological deficits. Rest of the systemic examination was within normal limits. The patient had initially been evaluated and admitted under internal medicine with a provisional diagnosis of headache with primary hypertension. The differential diagnoses considered as per clinical notes were myasthenia gravis and Tolosa-Hunt syndrome. The patient was managed with analgesics, antihypertensives, drugs for vertigo and steroids, which was essentially symptomatic treatment. An ophthalmological consultation was sought during office hours the next day. Before coming to ophthalmic evaluation, let me please briefly mention that the baseline investigations and investigations for myasthenia gravis and autoimmune disorders were within normal limits. A bilateral carotid Doppler was also within normal limits. On ophthalmic examination, the patient had an aided visual acuity of 6/9 and near acuity of N6 in both eyes. There was an obvious face turn to the right side due to right abducens palsy. There was also a mild ptosis in the right eye. There was esotropia with complaint of diplopia in primary gaze. There was limitation of abduction in the right eye. Anterior segment examination revealed anisocoria in the form of meiosis of the right eye, which was greater in the dark. There was nuclear sclerosis in both eyes, which explained the impairment in vision. Fundus examination was within normal limits in both eyes. So based on presentation and clinical evaluation, we had a patient with painful sixth nerve palsy, along with headache and diplopia, with signal towards a compressive lesion. The mild ptosis was likely due to Muller muscle paralysis. Together, these features suggested a lesion within the cavernous sinus in the internal carotid artery region, possibly an aneurysm or thrombosis, because this is the region where both abducens nerve and sympathetic plexus lie in close proximity. This is in fact a symptom complex known as Parkinson's syndrome that has been reported in literature and is an important method of localization of lesion in such patients. Our diagnosis was confirmed by radiology, which revealed a saccular aneurysm of the internal carotid artery in the right cavernous sinus, as can be seen in plain and contrast-enhanced MRI images of the patient in the axial and sagittal views. Following confirmation of diagnosis, the patient underwent endovascular placement of a flow diverter stent within the cavernous segment of internal carotid artery. This procedure was undertaken in a tertiary care center as the facility for interventional radiology was not available at our center. Following surgery, the patient had an uneventful recovery with gradual resolution of symptoms. This is the post-operative picture of the patient. There is orthophoria in primary gaze with recovery of ocular movements. A residual ptosis, however, has remained. To reiterate, a sudden painful nerve palsy should always be suspected to be due to a compressive lesion, though imaging is crucial in localization of the lesion and even treatment of the case. A casual clinical examination can lead to loss of precious time in ordering the correct radiological investigation. In this case, the initial treatment was targeted toward control of pain and blood pressure and prophylactic steroid. The initial differentials considered were myasthenia gravis and Tolosa-Hunt syndrome, neither of which fits the clinical spectrum of this patient. Parkinson's syndrome is a symptom complex which has been reported in literature but is still not common knowledge. It is essentially the presence of ipsilateral abducens palsy with mild ptosis and no features of other cranial nerve involvement. This suggests the presence of lesion in the cavernous sinus of the internal carotid artery, causing damage to abducens nerve and sympathetic plexus due to close proximity, leading to lateral rectus palsy along with the postganglionic Horner syndrome. Identification of such lesions clinically can lead to prompt and effective radiological investigation and management of the patient. To conclude, a painful cranial nerve palsy is a neuro-ophthalmic emergency and should raise the suspicion of a compressive lesion. A careful clinical examination can accurately localize the lesion while awaiting imaging results. Crucial time should not be wasted in symptomatic treatment without concrete evidence, and a high index of suspicion is important in preserving sight and life. This case is an excellent example of how simultaneous multidisciplinary approach can lead to prompt and effective treatment of a potentially life-threatening condition. These are my references. Thank you.
Any questions by the audience? Okay. Thank you, Dr. Anuradha.
Thank you.
So the next presentation is unilateral lateral rectus palsy as the initial presentation of a pineal region tumor in a child. Presenting author is Dr. Kedar.
Relatively uncommon in pediatric age group, it requires careful evaluation. The abducent nerve, which innervates the lateral rectus muscle, is vulnerable due to its long intracranial course. Lateral rectus palsy produces impaired abduction, manifest as esotropia, diplopia in older children, or abnormal head posture. If we report a case of a sudden onset lateral rectus paresis in a 14-year-old child. A 14-year-old girl presented with sudden onset of right gaze deviation towards the nasal side. She also gives a history of fever with headache for 1 week. Lab report showed elevated viral titer and being treated for typhoid. On examination, in primary position, 15 degree of esotropia was noted. Extraocular movement showed mild restriction of abduction, dextro elevation and dextro depression in right eye, with the rest of the ocular movements were normal. Visual acuity, rest of anterior segment evaluation and fundus were also within normal limits. This slide shows mild restriction in the lateral gaze, right lateral gaze, dextro elevation and dextro depression. MRI was done. MRI revealed an infiltrative midline mass measuring 45 into 52 into 43 arising from the left thalamus and dorsal midbrain in the figure 2. The lesion caused obstruction of cerebral aqueduct and lateral ventricles, which can be seen in the figure 3, with the mass effect resulting in displacement of right thalamus and adjacent midbrain structures. The child was referred to neurosurgery, where she was diagnosed diffuse midline glioma and underwent surgical decompression of the lesion with autologous cranioplasty. Histopathological analysis confirmed the diagnosis of diffuse midline glioma involving the left thalamus. Following the surgery, the patient received the 5 cycles of radiotherapy. On follow-up evaluation, ocular alignment was restored to orthophoria with preservation of good visual acuity, indicating a favorable functional outcome despite the presence of infiltrative midline tumor. Isolated sixth nerve palsy in children can arise from a wide spectrum of causes, including vascular, traumatic, inflammatory, infectious, neoplastic, and idiopathic etiologies. Unlike adults, where microvascular causes are more frequent, pediatric presentation often suggests more serious intracranial pathology. Thorough evaluation is therefore essential to avoid delayed or missed diagnosis. In this case, a comprehensive ophthalmological assessment provided the initial clue, while neuroimaging confirmed the presence of an infiltrative midline glioma. Early identification allowed timely neurological intervention and adjuvant radiotherapy, ultimately leading to preservation of vision and orthophoria, highlighting the value of multidisciplinary management in such presentation. Prompt evaluation and timely referral provided in facilitating accurate diagnosis and effective management in this case. These two images present the pre and post treatment. In treatment, we can see 15 degree of esotropia in primary position at the initial presentation, and post-treatment orthophoria was attained. Thank you.
Any question? So if the sixth nerve palsy is due to raised ICP, what would be the presentation?
In the fundus examination, we could find papilledema.
Any other finding? Your presentation is unilateral. In raised ICP,
It can be bilateral.
yeah, it can be. Thank you. So the next case for the presentation is novel NDUF V1 mutation causing progressive optic neuropathy, a rare mitochondrial complex disorder. The presenting author is changing of presenting author is not allowed. Yes. Okay. What is the name? Doctor? Tulsi Singh. Same. SIRI. Tulsi. Siri. LA. SIRI. TULASI Tulsi.
A very good morning. Today I am going to present a paper titled Novel NDUFV1 Gene Mutation Causing Progressive Optic Neuropathy, a Rare Mitochondrial Complex 1 Disorder. Coming to the objectives, it is for understanding the expanding phenotypic spectrum of NDUFV1 mutations beyond the systemic Lee-like syndromes to isolated optic neuropathy, to explore the mutation type as a driver of organ-specific vulnerability in mitochondrial complex 1 deficiency, and highlight the need for further genotype-phenotype studies and targeted therapies. A 10-year-old female presented with gradual progressive diminution of vision since 3 years with headache on and off, with complaints of squint in left eye since childhood. She only had a only had a history of 5th-degree consanguineous marriage between parents and left eye anisometric amblyopia in mother. Her ocular examination showed best corrected visual acuity of 6/24 in right eye and 6/60 in left eye, with the extraocular movements full painless in all directions, with the pupil sluggishly reacting to light with 15 degrees exotropia in left eye, and rest of the examination being normal. Coming to the fundus examination, the bilateral eye showed temporal pallor. And coming to the investigations, GAT is normal and perimetry showed low reliability, and color vision is deficient in both eyes. Coming to the MRI brain and orbit, the mild atropic bilateral optic nerve showing mild stir hyperintense signal and prominent perioptic CSF space. And T1 hypointense and T2 flare hyperintense signal involving the genu of the corpus callosum and forceps minor with small patchy areas of encephalomalacia, which would represent toxic or metabolic etiology. So the lab investigations showed elevated lactate and increased TSH, and G6PD levels were decreased, and normal galactosemia levels were seen, and 17-hydroxyprogesterone levels were elevated. And a complete panel for amino acid, fatty acid oxidation and purine metabolism disorders was done after pediatric referral, and everything came out to be normal. Then we went for whole exome sequencing, where she was found to have an NDUFV1 gene mutation with the transcript NM007103.4 with a variant of C1156C, that is cytosine is repressed by thymine, and so in the protein component, the arginine amino acid at 386th position is replaced by cysteine, and it showed a homozygosity on exon 8 with mitochondrial complex 1 inherited as autosomal recessive. Based on the ACMG classification, it is a likely pathogenic, and the whole genome mitochondrial NGS analysis came out to be normal. And coming to the Sanger sequencing, the patient is found to be homozygous, while the rest of the family, both the parents and the sibling, found to be heterozygous. And this is the electrophoregram sequencing shown where the variant in the NDA of V1 gene showed a homozygous variant in the proband where the heterozygous spike is seen in rest of the family. Coming to the, this is a pedigree chart showing the 5th degree consanguineous marriage with autosomal recessive pattern of inheritance. Coming to the differential diagnosis, this is a confirmed case of mitochondrial optic neuropathy supported by clinical features and NDU of V1 gene mutation. Coming to the treatment, coenzyme Q and riboflavin 10 mg OD were given, and after genetic conservation, idebenone was started. This is an illustration of an inner mitochondrial membrane. In the inner mitochondrial membrane consists of the 5 complexes, and the first complex, third complex and fourth complex were responsible for proton transfer, and the 5th complex shows the production of ATP. And in the inner mitochondrial membrane, where in the complex 1 there will be the NDU of V1 gene, which is the nuclear encoded subunit, which is responsible for this mutation seen in this case. When the NDU of V1 gene mutation was present, there will be a non-functional complex 1, which leads to decreased production of ATP. Then the idebenone is used, and it converts directly to idebenol, which produces ATP. Coming to the literature review, the current case is the first report of optic neuropathy as a predominant phenotype, which expands the clinical spectrum. NDU of gene mutations are can present as isolated progressive optic neuropathy, and this case highlights the heterogeneous expression of NDU V1 related mutation type may dictate organ involvement. These are my references. Thank you.
Any other disorder with mitochondrial gene mutation?
Yes, ma'am. There are other genes, like even not just NDU of V1 gene, there are other NDU of FS gene, and there are iron sulfate gene mutations, and there are also, these are actually nuclear encoded. There are also mitochondrial encoded, like MELAS and everything will come under mitochondrial encoded genes, which would, that actually mitochondrial encoded genes, we have to see only the mitochondrial next generation sequencing for such cases. But this is actually nuclear encoded gene. So we went for whole exome sequencing. But in other cases, there will be like MELAS, there will be, there are many, in the complex 1 also there are genes, other genes which I showed in the picture, NDU of FS gene 1, 2, 3, and also nuclear mitochondrial encoded genes will have a mutation.
Okay, thank you. So the next case is case report on Gradenigo syndrome. The presenting author is Dr. Shivani. Dr. Shivani, is she here?
Kalyani is there? She'll be presenting the case of decoding diagnostic dilemma, juvenile double seronegative myasthenia gravis.
Good morning, everyone. So my paper is on decoding diagnostic dilemma in juvenile double seronegative myasthenia gravis. So myasthenia gravis is an autoimmune disorder usually caused by antibodies against acetylcholine receptors and anti-MuSK antibodies. However, when these are absent, we call it as double seronegative myasthenia gravis, and it leads to delayed diagnosis and treatment. So the objective of my study was to describe clinical features, serological profile, and response to neurophysiological tests, specifically in children with double seronegative myasthenia gravis. It was a cross-sectional retrospective analysis, and local ethics committee approval was done. So we included all the children presenting to us with fluctuating muscle weakness and fatigability, in whom acetylcholine receptors and anti-MuSK antibodies were negative, and they were labeled as double seronegative myasthenia gravis patients. And after that, we performed extended antibody testing like LRP4, ASCA, and COOCT with RNST. So factors which were analyzed at 18 months follow-up were age of onset of disease, distribution of weakness, generalized or ocular, myasthenia gravis composite scale, serological and neurophysiological profile with therapy and outcome. So the outcome measures were defined as adequate response for more or equal to 3-point fall in MCG score with pyridostigmine and steroids, partial response with less than 3-point fall in MCG score and pyridostigmine steroids plus need of immunosuppressants, refractive response with no improvement with steroids or at least 2 other immunosuppressants. So the results were we had 52 children over 3 years with possible myasthenia gravis symptoms, and out of those 8 patients were negative for both the specific antibodies, and they were termed double seronegative. Mean age was 12 years and male to female ratio was 2:6. In these 8 children, we did all the extended antibody profile, and out of them 3 were positive for LRP4, and the MGC score was 3, and the response was adequate. This also told us that LRP4, the patients who were positive for LRP4 had good prognosis, and coactine positive were 2 patients, and one of them required immunosuppressants. So this tells us that prognosis is little bit poorer than patients with LRP4 positivity. Out of these 8 patients, 3 were inconclusive, and ASC was positive in 0 patients. All these 8 patients were subjected to RNST. So 5 were positive for RNST and 3 were negative for RNST. Out of these negative RNST patients, 1 was positive for single muscle EMG. So this tells us that single fiber EMG is the most specific and most sensitive test for myasthenia gravis. So to emphasize this was a case of intermittent exotropia. So it was such a good mimicker that it never developed ptosis. It was always intermittent exotropia, and the patient was operated for the same. And then it was thought that there is residual exotropia, but after 6 months of surgery, first time he developed ptosis. After that, IcePack tests were done and the antibody panel was done, and he was still negative for the 2 main antibodies which are routinely done, and he was positive for LRP4. And after starting medical therapy, he actually improved. So this is how double seronegative myasthenia gravis can be missed and confused with other factors, because not every case presents very typically with ptosis as a first sign. So what we already know is that 15% patient with generalized myasthenia gravis and 50% with ocular forms of disease are double seronegative. It has been already proven in literature. But multiple antibodies involved of most common are anti-LRP, anti-titine and coactine. So most studies are done in adults, but we just studied children. So what we found in this study was pediatric ophthalmologist may be the first contact doctor in a double seronegative patient. So if we do a extended antibody panel and pick this diagnosis early, we can actually save them from going to a generalized myasthenia gravis. So LRP4 is most common antibody with excellent prognosis. Coactine positive cases may need immunosuppressants is what we found from our study. And single fiber EMG is the most sensitive, even sensitiver than RNST. So successful myasthenia treatment requires early diagnosis, high clinical index of suspicion, and diagnosis is a dilemma. So a cocktail of clinical tests, serological tests and electrophysiological tests are needed. So treatment adheres to guidelines and prognosis remains excellent if we pick this up early, and so yes, we should have high index of suspicion in children, especially if we are seeing the symptoms, clinical features, but the most commonly done antibody panel is negative. So that is all. These are my references. Thank you so much.
What's the duration of treatment?
So ma'am, we worked with a pediatric neurologist also for the systemic doses of pyridostigmine and steroids if needed. So till the symptoms, they start on a loading dose for 2 months, and after that for 3 months they put them on maintenance dose. And in a period of these 6 months, they see how they have improved clinically, and after that, after 6 months, they decide. If they have not improved, they start them on immunosuppressants or steroids. If they have improved, then they slowly taper the doses. Yes, ma'am, there were recurrence. In of one of the cases, after 2 years, there was recurrence, and they again put on pyridostigmine. Yes.
Apart from this serology test, did you see regarding the status of thymus gland in these children?
Yes, ma'am. In 2 patients, this was done. CT MRI of the
CT MRI was
yes,
done?
yes, yes.
And thymectomy was done in any of the child?
No,
Surgical?
ma'am. No, nobody had thymoma, so
Nobody had thymoma in all these children?
Yes, ma'am, nobody had.
Go. Question? Yes, ma'am. Mic दे दो.
It's a nice case you presented, but since the beginning of our medical education, we are taught when you hear hooftops, think of horses, not zebras. So have you done the nutritional status of the child? What is the calcium levels? Is there any vitamin deficiency? And you want to diagnose untraditional illness where everything is negative, and you want to pinpoint a double zero negative myasthenia gravis and subject the child to a lifelong treatment without ruling out nutritional deficiency? That's point number one. Secondly, why surgery? If it is because of acetylcholine deficiency and you treated it, why surgery? Thirdly, how frequent? What is the prevalence and incidence of this? So it should not be that you want to look for something and that is why you are looking for it.
Ma'am, first of all, in 52 patients, the prevalence of was about 8 patients in the whole 52 patient or children. Yes, ma'am. The pediatric neurologist had done all the lab tests, all the systemic lab tests before starting the treatment.
They might have been covered in the history part, maybe.
I just mentioned lab tests
Yes.
to
Yes. Thank you, Dr. Kalyani.
Thank
Now
you,
we
sir.
move on to the next presenting author, Dr. Divya. Is she here? Dr. Divya, she is not here. Dr. Farnaz, she'll be presenting of optic nerve meningioma and glioma, a clinical radiological diagnosis.
Hi, hello, and a very good morning. I'm Dr. Farnaz, and we'll be discussing on optic nerve glioma and optic nerve sheath meningioma. Are these tumors a clinico-radiological diagnosis? So optic nerve gliomas are relatively rare lesions which comprise about 1% of the intracranial tumors, still the most common optic nerve tumor, whereas optic nerve sheath meningiomas constitute about 1% of meningiomas, second most common optic nerve tumor after gliomas. Still, why is this considered as a diagnostic difficulty? First reason being the rarity of the disease, and then because of all the reasons listed on the left side of your screen. Ours was a retrospective study where we analyzed 36 optic nerve tumors, 15 gliomas and 21 meningiomas for the following as given on your screen. The mean age was 15 years among the glioma patients and 53% were males. And 43 years was the mean age in the meningioma group and 57% were females. The main clinical features were protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, and disc changes included a normal disc, mild pallor of the disc, severe disc pallor, hyperemia with choroidal folds and optociliary shunts as well. The mean duration of symptoms among the glioma patients was 52 months and 73 months among the meningioma patients, with most of them having protrusion and diminution of vision. The appropriate imaging for these tumors is MRI brain with orbits with contrast enhancement. On the left side, glioma shows enlargement of the nerve itself, hypointense on T1. However, a soft tissue mass along the optic nerve sheath on your right side, hypointense on T1, is suggestive of meningioma. In T2 weighted images, glioma displays high signal intensity and is definitely hyperintense, whereas a meningioma is either iso to hypointense. Contrast enhancement is seen in both, but gliomas are usually irregular and botchy, whereas meningiomas regular, circumferential enhancement with centrally non-enhancing optic nerve. The treatment strategies for gliomas, in our series, chemotherapy was given in 7%, usually for children under 3 years of age group, until they get fit for radiation therapy, and 67% received radiation. Among the meningioma patients, the widely used treatment strategy was stereotactic radiation, almost done in 95%, with incisional biopsy and debulking required only in few ambiguous cases when there is disfiguring proptosis. EBRT, how is it done in such cases? First, the T1 weighted axial and coronal images are registered with a gadolinium enhancement are registered with a planning CT. The gross tumor volume is defined as the area of contrast enhancement, and this, when expanded by 1 centimeter in all directions, gives you the planning target volume. The target specific gradient of radiation therapy. So first, the area of the tumor, which is the area of interest as marked in the first image, receives 95% of the prescribed dose of radiation, followed by the second image showing the surrounding area, which receives 50% of the remaining radiation, and the third image shows 20% of prescribed dose of radiation, and thereby preventing collateral damage. So these are our pre-op and post-op patients who had excellent improvement in vision or stability of vision with significant resolution of the strabismus as well and the tumor size as well. For meningioma, the pre-EBRT and post-EBRT images show resolution of proptosis and improvement of vision with reduction in the meningioma size as well. So our study stands out from others in a way that both the optic nerve gliomas and meningiomas were analyzed. Diminution of vision and proptosis were the main clinical features, and MRI brain with orbits and contrast enhancement was done in 100% of patients, and also neuroprotective EBRT was the mainstay of treatment. So to conclude, gliomas and meningiomas can be diagnosed clinico-radiologically, thereby restricting surgical intervention only to cases of disfiguring proptosis and intracranial extension. So early diagnosis with fundus examination, requesting the correct MRI, precision reporting, easier access to neuro-ophthalmologists or ocular oncologists, timely and etiology-based treatment with EBRT thereby leads to better visual outcome and stability. Thanks a lot.
Very nicely presented and very clinical features they were demarcated. Very nice presentation, Doctor.
Thank you, ma'am.
Any questions? Anyone want to ask any questions?
So, thank you. So the next presentation is retinal nerve fiber layer thickness in transfusion-dependent thalassemia patient. Presenting author is Dr. Yesha Gupta.
A very good morning, everybody. Today, I'll be talking about retinal nerve fiber layer thickness in transfusion-dependent thalassemia. As we all know that thalassemia is a hereditary illness which requires lifelong transfusion. Such patients, they suffer from iron overload and they require chelation therapy. So this chelation-induced toxicity is very damaging to the retinal tissue because it is a tissue with high oxygen demand. So various clinical manifestations of thalassemia like cataract, angioid streaks, retinal pigment epithelium degeneration, BRVO, increased tortuosity of the retinal vessels, drusenoid deposits in the perifovea, hypo and hyperpigmentary changes, particularly seen in desferoxamine therapy, they all are well documented. But retinal nerve fiber layer, which is also susceptible to anemia-induced hypoxia, is something which is still unexplored. So we tried our study where we tried to compare the central macular thickness, ganglion layer thickness, and peripapillary retinal nerve fiber layer thickness using spectral domain OCT. We basically took around 170 patients of 85 thalassemia patients who were seeking treatment in thalassemia daycare unit with 170 eyes of 85 patients who were there for regular treatment. We included the patients between 5 to 30 years of age and excluded the patients who had history of any retinal disorder, diabetes, intraocular surgery, optic disc disease, or any history of ROP. Now talking of demographics, the mean age in the case group was 18.29, while that in controls was 20.87. There were 61% males and 39% females. Then we compared the systemic parameters like the respiratory rate and the heart rate, which was higher in the case group. and it was probably because of the chronic anemia and the increased cardiovascular requirement of these patients. Now, talking of retinal nerve fiber layer thickness per se, which interestingly was thinner in cases, that is 93.47 in cases and 96.23 in controls, p-value came out to be 0.08, which was significant. Similarly, in the inferior quadrant, the p-value came out to be 0.013, which was again significant. In temporal quadrant, it came out to be 0.016, again significant. Similarly, in nasal quadrant also, we came across significant results with p-value of 0.023. But in the superior quadrant, the values, they were not significant. There was no significant thinning in the superior quadrant. We compared the average retinal nerve fiber layer thickness. We tried to correlate with systemic parameters like duration of chelation, average hemoglobin over 5 years, average transfusion requirement, serum ferritin levels, liver iron concentration, and cardiac MRI, but we were not able to find any correlation. We also compared central macular thickness and ganglion layer thickness. Central macular thickness was not significantly different, but ganglion layer thickness was. We reviewed the literature. We came across this article by Ozone et al., where we found that there was global thinning, and there was thinning in all the quadrants except in superior quadrant, which was similar to our findings. Then Haag-Pina et al., he took in account adult patients, and he found that RNFL is preserved across all the quadrants. Then Fedos et al., he conducted the study in pediatric patients, but there was high heterogeneity. Then Dorson et al., he demonstrated significant reductions in retinal vessel density and enlargement of foveal avascular zone. Such vascular changes, they may precede structural alterations, which suggests that OCTA could be an adjunct to identify subclinical disease in thalassemia. Our study had few limitations as it was a cross-sectional study, so it limits conclusion about temporal progression, and age-dependent ocular development complicates the interpretation of structural changes. Axial length, refractive error, which were not measured, could also influence retinal nerve fiber layer thickness. Now, the variation in findings across studies are likely due to differences in age distribution, disease duration, iron load, and chelation therapy protocols. Younger patients, they may experience more pronounced early neurotoxic effects of iron, while older patients, they benefit from adaptation or prolonged treatment. Our study strength lies in its relatively large cohort and its stratified analysis, which helps bridge pediatric and adult data. Thank you. Ma'am, such patients, they were having some ocular manifestations in the past, but this is something which can help the pediatrician to titrate the iron levels and the chelation therapy, because there are two studies which they have some correlation with the chelation, the duration of the chelation basically, and the type of the chelation therapy which they are using. So it could help in that context that the chelation which they are using, if it is leading to more RNFL thinning, then that could be stopped.
So we are call upon, yes.
Not thin. Why this difference? Because it is a systemic illness, it affects every part. That's one. And very significantly, you've noted our findings are also matching up with some other paper. I mean, that need not be. That's one. Secondly, your first slide itself says that there are pre-existent retinal lesions. And in your huge number of 130 odd patients, it's very difficult to imagine that they didn't have any retinal findings to start with. Because thalassemia is an anemic disorder. They are getting this blood, repeated transfusions. And a pre-existing other retinal findings is a very common thing. And your statement that none of them had any other retinal problem when we started this, that's one. Then why are you saying that iron is the culprit, while anemia itself can cause a lot of things? So these are my three questions.
So ma'am, the answer to your first question is that there are a lot of studies which were conducted, and the results, they were variable in almost all the studies. Some said that there is a superior preservance of the RNFL, some said there are inferior, but some also concluded that there is no thinning at all.
So you have findings where the retinal picture is absolutely normal and there is retinal thinning. Is it that way? Like clinically you don't have any findings?
Ma'am, we had 250 patients. We excluded...
130 odd you said?
We had 250 patients registered in our thalassemia unit. We excluded all the patients who were having even a minute form of any retinal disorder, and then we have chosen this 85 patients for our study actually.
Achha. And study is over how many years?
Study we conducted for these patients, they are already seeking treatment in our thalassemia daycare unit from last 15 to 20 years. We have just chosen this patient because it was a cross-sectional study. We excluded all the disorders and then we have chosen these patients.
This is over, these OCT findings are over, 3 years, 5 years, 10 years?
No ma'am, it was just a cross-sectional study. We just take it at the moment and we compared it.
Thank you. So we call upon Dr. Suchita Gupta. Is she here? Yeah, welcome. The topic is a clinical review of Miller-Fisher syndrome, a rare variant of Guillain-Barré syndrome.
Good morning, everyone. MFS is an autoimmune mediated peripheral neuropathy associated with anti-GQ1B neuronal antibodies. It's a monophasic self-resolving triad of ophthalmoplegia, ataxia and areflexia, first described by Charles Miller-Fisher in 1956. It belongs to the GBS spectrum. It represents 1 to 7% of all the GBS cases worldwide. It has a higher prevalence in East Asia and 19 to 25% alone in Japan. Mean age of onset is around 35 to 45 years and with a male to female ratio of 2:1. It has a seasonal variation. It is an autoimmune mechanism triggered by molecular mimicry. Anti-GQ1B IgG antibodies are found to be positive in 85 to 90% of the cases. GQ1B ganglioside is expressed in the paranodal regions of the oculomotor, trochlea, abducens nerve, and the dorsal root ganglion of Mersal spindles, thereby explaining the triad. It has a common preceding infection, example, Campylobacter jejuni, influenza virus, CMV, EBV, and Haemophilus influenza. Why is MFS self-limiting? It is a transient immune-mediated pathophysiology. It is mediated by anti-GQ1B antibodies following an antecedent infection. The autoimmune attack is short-lived, halting once the antibody titers decline. The damage is mainly functional. It shows a nodoparanodopathy rather than a widespread axonal loss. This means conduction failure is caused by antibody binding at nodes or paranodes, not by permanent destruction. Since this is functional and reversible, normal conduction returns after immune resolution. It has a minimal or no axonal degeneration. Unlike axonal variants of GBS, MFS largely spares the axons, thereby the preserved axonal integrity allows rapid remyelination and recovery without major sequelae. In our case, a 37-year-old male presented with complaints of double vision and blurring of vision since past 3 days. His medical history was unremarkable. He had a history of difficulty in walking since 3 days. Patient gives history of abdominal pain along with diarrhea for 4 days, 2 weeks back, for which he took medication and was relieved. Clinical findings, his visual acuity was aided 6/9 in both eyes. Fundus examination and slit lamp examination were within normal limits. He had a 15-degree exotropia in the left eye and there was no abnormal head posture. Eyeball movements was restricted more in the left eye and more so in the superior quadrants. We can see here mainly the restriction is in the superior and the medial quadrants and more for the left eye. MRI brain with orbit was normal. CSF study shows albuminocytological dissociation. Serum anti-ganglioside antibody panel was ordered and serum anti-GQ1B IgG was positive. NCV study was suggestive of pure motor demyelinating polyradiculopathy with axon loss affecting bilateral lower limb more than bilateral upper limb. We have an MRI here which shows it was absolutely normal, thereby eliminating any chance of stroke or encephalitis. Management outcome, patient received 4 doses of injection IVIG 34 gram IV OD for 4 days. Patient showed significant resolution of ophthalmoplegia and ataxia over 2 weeks. No residual neurological deficit at 2 months of follow-up. Summary, early recognition of the triad by ophthalmologists is crucial. Prompt antibody testing and initiation of IVIG optimized outcomes. Awareness of the benign, self-limiting nature prevents misdiagnosis and unnecessary intervention. Ultimately, timely ophthalmic suspicion can change the trajectory of this disease from a potentially alarming neuro-ophthalmic emergency to a condition with excellent recovery and minimal long-term sequelae. Thank you.
Any question?
Thank you for the session. Thank you, audience. Now I request all the speakers to come over here for a group photograph. Divya Katta? Okay, now another speaker is here. She'll be presenting a rare case of ophthalmic migraine involving all three oculomotor cranial nerves. Dr. Divya Katta. Is Dr. Shivani over here?
Good morning, everyone. I am going to present a rare case of reversible ophthalmoplegia in a chronic migraine. Is it just a migraine? So once we go through the traditional methods of solving a case so we have a presenting complaints of sudden drooping of left eyelid since left 1 week, limitation of eye movements, and diplopia on all gazes was seen when lid is elevated. So by the history, presenting complaints itself, we would go to the conclusion of is it a third cranial nerve palsy? But is it really just third cranial nerve palsy? Going back to the history, we see that is a 40-year-old female with history of throbbing headaches in 6 years, 2 to 3 episodes per month associated with nausea and photophobia, and diagnosed as migraine already and on treatment since then. There is no systemic illness, no history of trauma before presenting the complaints. And going back, she has headaches on the left side, 2 to 3 episodes in the past 1 month, and then developed drooping 1 week later. So by this, we usually conclude that it could be a migraine associated with a ophthalmoplegia. So on examination, best corrected visual acuity is 6.6 in both the eyes and N6 for near vision. Complete ptosis of left eyelid is seen, and diplopia on all gazes with lid elevation. And the pupil reaction is unaffected, both direct and indirect. So what we see next is an extraocular movement. We see there is limited abduction, levo elevation, and levo depression involving the lateral rectus, suggestive of 6th cranial nerve palsy as well. So apart from 3rd cranial nerve, which we have already decided, now it is added up to 6th cranial nerve palsy. So looking at overall extraocular movements, we see there is limited dextro elevation suggesting inferior oblique, limited adduction suggesting medial rectus involvement, and limited depression suggesting inferior rectus involvement, whereby we have decided now that there is third nerve involvement as well. And for the surprise, we have limited dextro depression in the left eye, which shows there is 4th cranial nerve involvement as well, superior oblique. So other cranial nerve examination was within normal limits. Facial sensations, corneal sensations were also normal. So the fundus examination was also within normal. There was no changes in the fundus. So by now we have total all the 3 cranial nerves involved. So the differential diagnosis could be cavernous sinus syndrome, orbital apex syndrome, Tolosa-Hunt syndrome. So there is a plethora of diagnoses where we can add up to this, where trauma, tumors, vascular, and inflammation are the main cause of involving all the 3 cranial nerves. So trauma, there is no history. Vascular, there is no history of diabetes. There was no hypertension. And for tumors and aneurysms, we have gone through an imaging multiplanar MRI of brain and orbits, which turned out to be within the normal limits. So we have ruled out the differential diagnosis of aneurysms, Tolosa-Hunt syndrome, and diabetic cranial neuropathy. And by the history, we have also ruled out the cause for ptosis, which is myasthenia gravis, because there is no diurnal variation, which she has mentioned. So the final diagnosis we have concluded, depending on the typical headache history she had presented for the past 6 years, and there is new onset cranial nerve palsy, neuroimaging was negative, and there is no systemic illness corresponding to any of the complaints. And by the management, there was response to steroids as well. So we came to a conclusion of ophthalmoplegic migraine, which was renamed as recurrent painful ophthalmoplegic neuropathy by ICHD3 in 2023. So why is it a misnomer? Because it is not a migrainous headache as such, but rather a recurrent painful neuropathy presenting with repeated attacks of paresis of one or more oculocranial nerves with ipsilateral headaches. So the diagnostic criteria as defined by the ICHD3 are at least 2 attacks of headache before presenting with unilateral ipsilateral paresis of 1 or 2 or more than 2 oculomotor nerves. orbital, paracellar or posterior fossa lesions has been occluded by appropriate investigation, as we did in this case, and not accounted by any other ICHD3 diagnosis. So that means there is no migraine with aura, and also other facial headaches which could be diagnosed here. So we went ahead with the oral corticosteroids which with dose calculated as per the body weight and tapered weekly. So 6 weeks later, the ocular movements recovered fully in all cases, and there is complete recovery of ptosis, and there is no residual mydriasis. So these are all the ocular movements where we can see entire movements have recovered completely. To compare with the existing literature, we have only few case reports which have been presented. Lee et al. Had a case series of 8 cases which included in the age group of 23 to 65 years and associated with migrainous headaches. So the main points which has to be taken from here is that the present case we had a long-standing history of migraine and headache preceded the ocular signs. Recovery time was a little rather longer than the usual cases, which was 4 weeks, and she took around 6 weeks, and there was full recovery after the corticosteroid therapy. The other things we need to consider is that migraine history is variable. Some might present with a history of migraine, some might not even give a history of migraine altogether, and the sequential involvement, headache can precede ocular nerve palsy or the ocular nerve palsy can precede headaches. So there is no sequence to it. And the recovery time could be from days per episode to altogether 6 weeks or 8 weeks. And the steroids are ideally useful in all the cases. And few cases also reported involvement of the 5th cranial nerve as well. So we have to look out for the other cranial nerve involvement also in these cases. So to summarize, cranial nerve 3 is the most common involved cranial nerve. Abducens is the next more common, and 4th is the least commonly involved. Non-oculomotor nerves has to be looked out on 5th in cranial nerves, and there could be simultaneous or sequential involvement. So the take-home message is think of ophthalmoplegic migraine in patients with new onset cranial nerve palsy. Always exclude aneurysms, tumors and inflammatory causes. MRI can be normal, and steroid therapy is most of the times beneficial. Importance of follow-up to watch for recurrence progression is has to be taken into consideration. Thank you.
Okay, thank you. So for how long the steroid has to be given?
Steroid we have given for 6 weeks till we saw the complete recovery, ma'am. Depending on the dosage, we started with her body weight.
Okay.
And tapered at 5 milligrams. So we have completed the tapering till the 5 milligrams. Then.
Is any recurrence noted after stopping the treatment?
No.
In any other literature which you have read?
Recurrences have been there, but there is involvement of the other cranial nerves. That is sequential. There could be recurrence of the same cranial nerves as well.
What is the follow-up duration of your case?
6 months, ma'am. It has been reported in April. Now it's been 6 months.
Thank you.
Yes, ma'am.
What is the etiopathology? Like so many nerves getting involved. I mean, what exactly happens? And steroids, like it is a very random, almost empirical kind of a treatment that we have given. But what exactly has happened that all the nerves are involved and suddenly you give steroids? And 6 months is a very short period of follow-up.
Correct, ma'am. But she has presented to us in April, and some of the case reports have seen that there is thickening or enhancement of the optic nerve which is getting involved, which shows the kind of inflammation which they are seeing. We don't know the reason for inflammation as such. Because the reason is inflammation in few cases, we are going ahead with the steroid management.
So you have ruled out all hormonal anomalies like thyroid and
yes,
everything.
Usually the causes are granulomatous inflammations, which we have ruled out.
Tuberculosis and all that is?
Yes.
Okay, now we come to the end of this session. Thank you.
Final.
Okay.
One final talk is pending of Dr. Vikas Sharma, seeing the unseen optic neuritis, a senatal event in Sjogren syndrome.
Good morning, everyone. Today, I'll be navigating you all through a bilateral optic neuritis case, which is an unique case associated with an unusual etiology. Optic neuritis is an inflammatory demyelinating disorder of the optic nerve. As we all know, it has got multiple etiologies. However, multiple sclerosis being the most common. My patient is a 37-year-old female. She presented to us with sudden onset diminution of vision in the right eye. Which progressed over next 2 days. She had mild pain in both the eyes preceding the onset of diminution of vision. Only significant past history was she was using frequent lubricating eye drops. She was a diabetic since last 6 years and on oral hypoglycemic medication. There was no history of recent febrile illnesses, chronic use or cessation of any drug, recent weight loss or weight gain, any other long-term illnesses, and no previous similar episodes in the past. Her general and systemic examination, including CNS examination, was within normal limit. On extraocular movement, there was mild pain in adduction and the elevation of the right eye. She had dyschromatopsia, she had decreased contrast sensitivity, and pupil showed RAPD in the right eye. Her fundus examination revealed disc edema that was asymmetrical more in the right eye as compared to the left. Visual field showed superior altitudinal defect in the right eye. Left eye had few scattered non-specific defects. At this point, I have a young female patient, sudden onset diminution of vision, painful ocular movement, and bilateral disc edema. My first provisional diagnosis was bilateral optic neuritis, query MS or neuromyelitis optica spectral disorders. We promptly started our patient on pulse IV methylpred, 1 gram for 5 days. While we were waiting for investigations, which came out to be normal, her VEP had prolonged P100 latency in the right eye. Her CSF analysis to rule out oligoclonal band were within normal limits. NMOSD spectrum antibodies were also negative. She had mild atrophic changes in her MRI, also suggested changes in both eyes of optic neuritis. There was enhancement in both eyes. There was one particular finding of partially empty sella, which is associated with idiopathic intracranial hypertension. However, due to painful optic neuritis and without risk factor of IIH, it prompted us to further investigate this patient. We did an anti-nuclear antibody qualitative analysis, which revealed SSA positivity. Then we further reconsider the history of frequent use of lubricants and possibility of Sjogren's syndrome as an etiology of optic neuritis. We did a dry eye workup, which came out to be severe dry eyes. Our final diagnosis at this point, with the help of MRI finding, SSA positivity, and severe dry eye, was Sjogren's syndrome with bilateral optic neuritis. Since we had already started our patient on IV methylpred, soon we shifted her to oral steroid in tapering doses. We also started tablet azathioprine in the following doses, and her lubricants were continued. On day 6 of follow-up, she had improved in her visual acuity till 618 in the right eye and 66 in the left. Sjogren's syndrome is a chronic autoimmune exocrinopathy. However, literature suggests there are few extraglandular nervous system involvement as well. Optic neuritis is rare. However, despite having their typical sicca symptoms, the optic neuritis can be a presenting clinical feature. As per Jan R.L. et al., they did a population-based cohort study in the Taiwanese population. They showed the incidence of optic neuritis in Sjogren's syndrome is 10-fold higher as compared to the normal cohort. The prognosis depends if the optic neuritis is associated only with Sjogren's syndrome, or if there is some neuromyelitic optica spectral disorder, then the prognosis is grave. There are more severe episodes, higher rates of paraplegia, more morbidity, and long-term immunosuppression are needed. To conclude, optic neuritis can be a rare but a serious clinical presentation in patients of Sjogren's syndrome without its cardinal symptoms. Hence, it is important to have a higher threshold of suspicion, especially in patients of bilateral optic neuritis. Thank you so much.
Any question from the audience?
Again, ma'am. Sharma's 5 mm in both eyes, ma'am. Thank you so much. OCT. OCT we did not do in this patient.
Picture that you showed was not very clear. We could not make out much features of optic neuritis. The fundus photograph which was there, it was a wide angle photo and probably in a small pupil.
Okay, it was bilateral disc edema, ma'am.
It was not
So-
very visible in the picture at least.
Okay, because it is a
Yeah.
wide field photo.
And your field was showing a lot of field changes, which in papilledema generally doesn't occur.
Yes. we were
So
also
that is not matching up.
Okay.
Then you say that it is matched up with Sjogren's disease, and Sjogren's usually causes a very severe dry eye. So all this little, with a pinch of salt, the findings are
Okay.
a little mixed up.
We were also skeptical when we saw her field results because
then-
we expect enlargement of blind spot. However, altitudinal defects are very well mentioned
And
in
in
the literature.
MRI also, demyelination was not very visible. So, I mean,
Yes,
these
ma'am.
were my observations.
That's why we ruled out MS
Yeah,
in this
thanks.
case. Thank you so much.
So now we come to the end of the session. So please everyone, all the speakers, please come up for the photograph. इसमें रखना है ना?